Hello, everyone, and welcome to Citizens Reunited to Overcome Cancer. We call it the CROC Podcast. I'm your co-host, Angel Santana, and as always, it's an honor to be with you. Before we begin today's Rewind episode, I want to take a moment to acknowledge that our very own Dr. E, Dr. Tommy Anelli, is away this week due to an unexpected personal matter. On behalf of all of us here at the CROC Podcast, we want to send our thoughts and prayers and best wishes to Dr. E and his family. We're looking forward to his return and an all-new episode coming your way on November 9th. Now, as we continue to raise awareness this month, it felt only right to revisit one of our most popular conversations and our powerful conversations and episode about the one that truly embodies the heart of what this movement is all about. Today, we rewind to our episode featuring Dr. Charles Shapiro, a professor of medicine at Mount Sinai Medical Center. Dr. Shapiro is not only a world-renowned expert in breast cancer and transitional medicine, but also one of the true pioneers in cancer survivorship advocacy. His groundbreaking work has changed the way doctors and patients alike think about life after cancer, focusing not just on a treatment, but on living fully, thriving, and healing in every sense of the word. October, as you know, is Breast Cancer Awareness Month, a time when we come together as a community, survivors, thrivers, friends, and families, to remind ourselves that each and every one of us, each other of something essential. Early detection, of course, as you know, saves lives. And if you've been putting off that screening or mammogram, let this be your friendly reminder. Make that appointment. Take care of yourself because your health matters, and so do you. At the CROC Podcast, we believe that you're not just a podcast. We're not a podcast. We're a movement. And a movement that stands besides every survivor, every warrior, and every loved one who has refused to give up hope. We're here to walk this journey with you, to educate, empower, and remind you that you are never alone. So as we hit rewind and revisit this conversation with Dr. Charles Shapiro, let's listen with gratitude for the science, the stories, and the strength that continue to inspire us all. My name is Angel Santana, and on behalf of Dr. E, the host of our entire CROC podcast and our podcast family, Citizens Reunited would like to thank you for being a part of this movement. Now, let's get back to where it all began. Episode 8, and the CROC Podcast starts right now.
Welcome to Citizens Reunited to Overcome Cancer, a show to make your survivorship an easier journey by providing information and advocating for you. A show to help practitioners up their game and their level of performance. This is the CROC Podcast. Here is your host, Dr. E, and alongside him to share some hope and inspiration from the Have Faith, Let It Begin podcast, co-host Angel Santana.
Welcome back, my CROC Nation friends. As promised, Dr. Charles Shapiro, professor of medicine, Mount Sinai. Dr. Shapiro, I want to first thank you, and I want to clarify this thank you. Of course, Angela and I are thankful for you coming on this podcast. It's a brand new podcast. We're still kind of figuring it out. And to have someone of your caliber who has done so much for our survivors to accept this invitation is certainly worthy of a sincere and genuine thank you. But as an oncologist myself, as a physician, as someone who really cares a lot about cancer patients, I wanted to thank you on a much deeper level. I wanted to thank you for you. I wanted to thank you for your career. I wanted to thank you for your work. I wanted to thank you for everything you've done, all of your innovations, which we went into in some detail in your introduction. But I wanted to thank you for your career. Thank you. And I mean that from the bottom of my heart.
Yeah, so you're welcome, and I'm thrilled to be here. I'm humbled that you asked me.
So as I told you offline, we were kind of going through the history of survivorship. We went through Dr. Mullen's contribution. He was already a great man whose vision to help with health disparities in his career was enough. And then he got struck with cancer. We almost killed him, right? His oncologist almost killed him. And then he went on to survive, have children, and have a great career. And I'm sure you guys rub shoulders trying to look at that arid landscape, which we now call survivorship. It wasn't even called anything in those days. And I just had mentioned to you, you found yourself in Boston at Harvard doing your fellowship maybe 2 years after the publication of this paper. And I kind of wanted to get your view now. We're looking 35 years later at, what the landscape was, even at, the best hospital in the world, the Dana-Farber, where, Stanley Farber did all that amazing, innovative work, and you're there in those hallways, and his ghost was probably, if not even, he wasn't even dead yet, there kind of walking the halls and kind of talking about survivorship and the special, milieu, which sort of had people involved, not just in the cure of cancer, but in advocating for the survivor and the special needs of the survivor. Give us your view from those days.
Well, those days are not dissimilar to what you found yourself, a desert, basically. No one was thinking about survivorship. Everything was focused on new drugs, like paclitaxel was new in the day, and adriamycin was new in the day. So we were all focused on curing the patient, but the after effects of treatment, particularly of survivors, was not in our radar screen. It's not on the radar screen. I did a quick and dirty back of the envelope calculation. And when Nixon declared war on cancer in 1973, there were 2 papers published with the title Survivorship. And it's been exponentially growing since then, but it was a bleak desert and nobody was thinking about it.
When you were, in Boston and then off to, I think you went to Ohio State after that, you were then sort of seeing a change. You were probably at those national level meetings, where the core curriculum from the American Academy of Medicine came up with those 10 tenets or whatever. Give us your view from those days.
Yeah, so those were quite a bit later, like 20 years later, they came out. And that was the first organized effort, I think, to really put survivors in focus as an unmet need group. And that was very useful. But I'll tell you the truth. Even today, survivorship is not integrated into the mainstream of cancer care. So I say that with a heavy heart. I wish it was, but we've made incredible progress in treating survivors and knowing about the difficulties they encounter, both financially and due to treatment, but it's not integrated into the mainstream of cancer care as yet.
That is very disheartening, actually, and I do agree with you. I think one of the frustrations I have, you from the medical oncology side and me from the radiation side, we see tumors shrink, we see them evaporate, and then we see these patients and we're very giddy. We're showing them their x-rays and we're patting ourselves on the back. And yet we're seeing a shell of a person. We're seeing a ton of harm. And I'm looking at your paper and it was just the paper was great. And we're going to try to get it on the website for people to review. But I wanted to say that just looking at some of these things that we do to patients as a cost, as a residue of cure, we talk about chronic pain, you talk about infertility, gonadal failure, neuropathies, you talk about fatigue, things we don't even think about, right? Insomnia, not being able to sleep, sexual dysfunction, metabolic syndrome, bone loss. And that was obviously, that's what made your insight into that, and we'll get into that in a second as an example. Cognitive dysfunction, cardiac damage, heart failure, valvular damage, dysfunction of the heart, fractures, again, your specialty, uterine cancers, secondary cancers, leukemias, all those types of things. And I have to say, from my point of view, and I'm going to let you comment, let you take the ball up. Here we sit and we're seeing these great cures, but we're seeing people devastated from what we do to them. So on the radiation side, of course, from the chemotherapy side, of course, I was wondering if you could address, those that table that was in your paper.
Yeah. So in addition to the things you mentioned, I think that chemotherapy, we're learning more and more of premature aging during chemotherapy. And chemotherapy causes a lot of things that are associated with aging. For example, telomere shortening is one thing. Cytokines that are associated with aging, proteins that are associated with aging. So chemotherapy causes premature aging. And one thing we both glossed over, I put it in the line in the paper, but financial toxicity. Many people can't afford cancer care, and they're losing their mortgages in their homes and back to work issues. You'd be surprised about the number of cancer patients that don't go back to work because of these problems. So financial toxicity is equally important to the personal problems these survivors encounter.
Absolutely. And I think you're reading my notes because I have all that, the telomere damage, and I was going to ask you about that. But using actually your innovative work with premenopausal women with breast cancer, talking about your insight as far as their bone loss, their diminished quality of life. Let's kind of use that as a model of an example of one of the special circumstances that are cancer survivors. So this woman with breast cancer, she's 46 years old. I'm sorry, we'll even go 36 years old, has a growing family. They get chemotherapy. They go into premature menopause. They start losing bone, and they're just basically their lifestyle is totally destroyed at this point. And you have this insight, this as I said, bench side to bedside, translational experience. And it really was groundbreaking, by the way. And when I thank you for that, as well as many other things. But that was especially important in our work. So let's use that as an example. A premenopausal woman getting chemotherapy, a perfect example of the special needs of our survivors.
Yeah, so there's two issues here. One is very frequently women who get adjuvant chemotherapy go into chemotherapy-induced ovarian failure. And that's associated with a lot of bone loss. And estrogens are protective against bone loss. And if you diminish estrogens, you make them in effect postmenopausal, then they lose bone, and they lose bone earlier than they would have had they not had breast cancer and not going through natural menopause. So it's a big problem. It's treatable. Awareness is the key. Awareness is the key, because getting DEXA scans, bone density scans, and knowing what to pull the trigger in based on those scans, pull the trigger in terms of anti-resorptive agents is the key. So osteoporosis is a preventable problem as long as you're aware that chemotherapy-induced ovarian failure leads to osteoporosis and leads to fractures. And one other thing, fertility is a big issue. And we've learned that fertility is an important concern, particularly in a young person, 35. She may want to have more children. So there's certain things you can do to preserve menstrual function, like adding a GnRH agonist like Zoladex to the chemotherapy that tends to preserve menstrual function. And in vitro fertilization would be another aspect of care in that group.
So in your clinic, in your breast cancer clinic, with this known, and again, it's not known everywhere, do you have access to these, these resources for your breast cancer patients?
Yeah, I happen to work in a major academic medical center, and I have all the resources. I'm not sure that everybody has the same resources distributed around the country, and that's an imbalance I'm always interested in interventions that are exportable to the community, because that's the common denominator. That's the area where the most patients are treated, not in the cancer centers, which are resource intensive, but in the community where most of the cancer care is delivered. So any interventions, I'm always thinking about, can we export them to the community, not just the cancer center?
Gotcha. And, that brings up two really important points. When you say not accessible, accessible to community centers, I'm in a community center that's only about maybe 90 minutes away from where your office sits. And that's with traffic. So we're very close to each other, yet we're worlds apart. Getting patients over in Orange County, Sullivan County, Dutchess County, we have anybody from the New York City policemen and firemen families up here to dairy farmers, who 8th generation dairy farmers, to just your good old blue collar worker kind of thing, trying to convince them to go into the city to see Dr. Shapiro and his crew is not always the easiest thing, not just financially, but also just logistically. So there are challenges we still have.
Yes, indeed.
So when we look at this scenario, again, each cancer patient is unique. You would agree with that. And you would say that each cancer patient who has finished treatment has challenges that are unique to their survivorship journey. You mentioned one that's extraordinarily curable, one that's treatable is this bone loss from women premenopausal women that are then rendered in ovarian failure. One of the things that I have found so difficult, and I wrote in my notes here, we almost feel like we have the impotence of caretakers, meaning that we try to repair the unrepairable. So we do this damage to people, and there are sometimes no really great fixes. So if there's a patient who I always look at my prostate guys, and they've had their prostatectomies, or not to, radiation oncologists always, poke fun at the urologist, but of course with radiation therapy, there's impotence and erectile dysfunction, and there's all sorts of things. We know our young people that we treated for Hodgkin's disease in the early days of our careers, that now have coronary artery disease, or they have secondary cancers. It's very frustrating because even we as specialists sometimes scratch our heads and don't really know what to do with these people. Peripheral neuropathies, with long-term dysphagia, dry xerostomia. These are all fancy words, everybody, for dry mouth and difficulty swallowing and taste of food, and of course, erectile dysfunction and things like that. But would you mind just commenting on that frustration from when you go into the clinic?
Yeah, so I'm frustrated too, but I think that there's a movement in oncology to de-escalate therapies. And Hodgkin's disease is a perfect example of de-escalating therapies, so that now there isn't so much coronary artery disease. That's in the old days when we used fields that were fields that were
the big mantle fields, those massive, yes, exactly.
So there's a big move to de-escalate therapy, and de-escalating therapy, the penultimate example of that is no therapy, which genomic assays in breast cancer have led us and proven that 75% of the patients can be spared chemotherapy and only 25% need it. So it's mechanisms like that, genomic testing for de-escalating therapy, Hodgkin's disease for de-escalating therapies, and other cancers for de-escalating therapies. That's a recognition, or the flip side, of these survivorship issues that are so difficult for people.
Yeah, and you also hit on just another important aspect of your interest and your contribution to the microRNA assays that you've been working on. Again, I promised the listeners that I would have you explain to them what translational medicine is, and you are the chairman of translational breast cancer at Mount Sinai. So maybe you can tell us a little bit about what you're working on.
Well, translation is nothing more than a two-way street, bench to bedside and bedside to bench. Scientists often know nothing or next to nothing about the clinic, and we as clinicians know everything about the patients, but have no idea about the science. So we have to work together, and translational research is a two-way street, bench to bedside, but bedside to bench in terms of observations made in the clinic that get explained in the lab. So that's what I'm pushing in my center, observations that are translated from the bench to bedside and bedside to the bench.
And again, as I said to the listeners prior to our part of the podcast, that's what makes you so special, is because you actually are able to bridge that. You are a clinician first and foremost, but also have a great deal of experience and interest in basic research, basic science. I'm sure you even go and teach medical students on occasion, I'm sure, some of these things. And that is a very special physician, because we as physicians, we sometimes make fun of the scientist nerds and things that are working on, cell cultures or whatever, but it takes a very special clinician. Clinicians respect clinicians, but we especially respect clinicians who also are investigators and scientists, and who do this research, who come up with these innovative ideas. So this is my 18th thank you to you, Dr. Shapiro. But again, I am going to now go into a little bit of a different direction, talking a little bit about some of the other aspects of your paper I wanted you to comment on. You then go into we talked about the unique circumstances of the survivor and what their journey will be and what they have to deal with. You also give a great deal of emphasis on things that other people don't: health promotion, psychological well-being, caring for our special populations, and especially recognizing and bringing into the survivorship mix, the caregivers. So I wanted you maybe to comment on that aspect of your paper.
Caregivers are the unsung heroes of cancer care. I mean, a lot of problems caregivers have are the same problems that survivors have: anxiety, depression, back to work issues, the same things that caregivers, cancer patients have as a consequence of therapy and having cancer. The caregiver, by proxy, is involved in the same issues. So we have to recognize and make programs for caregivers. And there's starting to be a trickling of those caregiver programs and recognition that there's two entities we have to treat: the cancer patient and the caregiver. Special populations, including the geriatric population. I have a curve in my paper that 65 and older are the number one group for now in the future that get cancer. So it's really geriatric oncology is a good thing to be in right now, because it's going to be a career that sustains you for the next 40 years. So special populations, the pediatric who becomes a adult, it gets treated for cancer and becomes an adult, and they fall in the crap. So there's a lot of special populations that are needing our attention in this survivorship realm.
Very well said. And I also wanted to say that when you were working with ASCO and putting this quote unquote core curriculum together from those 10 tenets that we've discussed, you mentioned care coordination and communication, meaning trying to get the primary care physician, trying to get the oncologist, trying to put everybody on the same page, treatment summaries, individualized care plans, identify gaps in research. I was wondering if you can tell us a little bit about that. I guess you call it the shared care model.
Yeah, so the shared care model is nothing more than what it says, sharing the care with another physician. And truly, primary care physicians can do it, can do survivorship care. They just have to be educated about what it is and what they have to do. So it's a model that integrates the oncologist with the primary care physician. The patient may be comfortable with the primary care physician in preference to the oncology because he or she has known him all their lives. So we have to be cognizant of the role that the primary care physician could play and should play in the care of our survivors.
Have these modules that you created and also teach, have they trickled down to the primary care sector?
It's a challenge that primary care physicians sometimes don't want to bother with oncology patients. They say, okay, turn it over and the oncologist is responsible. But there's a lot of things that we don't know about, like hypertension. When was the last time you treated hypertension or diabetes?
You know, I treated hypertension this morning. One of my patients on clinic had high blood pressure, and I sent him to the emergency room. So that's how I treated their hypertension.
Well, my wife's a primary care provider, and, she knows the latest and greatest in diabetes and cardiac management. I don't know that stuff. I'm focused on oncology. So we need each other.
Yeah, we do. But that actually brings up a really another hole in our game. I hate to say, as physicians, we'd like to think that we're the greatest and everything, but we are so far short of that. We're very busy. Patients have these special needs. A patient comes in after treatment. We spend a lot less time with them than we do when they first come in, and we're trying to work up their case and trying to figure out how to shrink these tumors. We're really not that great at survivorship either.
Yeah, so that's why I advocate for nurse models, for example.
Yes, I was good. That was exactly where I was going.
Yeah, so nurse models of mid-level providers and nursing providers, they can do a lot of it too. They just have to be educated. And nurses have a special relationship, as you know, with cancer survivors. They're special, and they're special with all patients. So we should take advantage of the nursing aspect of that special relationship and teach them about survivorship. And they can do a lot of it too.
Absolutely. Last week we had a nurse practitioner who does the survivorship planning, with the patients. And I have to tell you, for this past, I want to say maybe 2.5 years ago, I hired 2 nurse practitioners. I was very skeptical. I didn't want to give up control of the clinic with the acute reactions. I have to tell you, they run circles around me. These 2 gals are amazing. And I believe, as you do, that this advanced caretaker, this, the nurse practitioner / PA model, I think that they would do a tremendous job that even a primary care physician can do, or even an oncologist can do, unless the oncologist is focused either on palliative care or focused on survivorship. So we are on the same page. But I wanted to ask you also, you mentioned risk stratifications. One of my interests, I guess you would say, even though I'm a generalist, is I love thyroid cancer. And I love thyroid cancer because patients usually do very well. But I also love the view of thyroid cancer. It's not a stagnant diagnosis. You're not a stage 3 high risk, tall cell papillary thyroid cancer forever. If you're treated, you have your surgery, you have your iodine, and then you basically your thyroid globulin goes down to 0 and your scans are negative. You don't stay high risk for your whole life. You're dynamically stratified. And I think that was so nicely said in your paper, that also survivorship risks should also be stratified into low, intermediate, and high. Tell me a little bit about that.
Yeah, so that's a concept that's in about the past 10 to 15 years, people have proposed that, like, a bone marrow transplant patient who's a survivor has a lot of needs, as opposed to a breast cancer patient who maybe got radiation and mastectomy, and that's it. So the idea of the intensity of the resources you have to throw at these people changes. And when you risk stratifying up front, you tend to be in a bit of a position to apportion the resources that the various survivors need.
Very well said. So I wanted to sort of end on a really positive note, and you had mentioned it, and I believe this is going to be the path. So one of the reasons why our survivors are so needy, and I say that with love, I don't mean they're needy, dramatic, needy. They're needy because we've hurt them, we've caused side effects, and they have special needs. The de-escalation over the next 10, 15, 20 years, when you and I are going to be retired in Miami and we're going to be playing pinochle on Monday and shuffleboard on Tuesday, pickleball on Wednesday, golf on Thursday, and we're not going to be in the game anymore. What do you see the future for survivors?
Well, I see the future is bright. We're developing new treatments for peripheral neuropathy, for example. De-escalation as a concept is recognized, and there are few dramatic examples that are already in place. I see the recognition of survivorship completely creeping in to the mainstream of cancer care over the next 30 years. It's like genetic counseling 25 years ago. That was an offshoot. It wasn't integrated. Now it's integrated. Nobody would do a breast program without genetic counseling. So survivorship is going to get there. And it's a long time in coming, but it's necessary. And we're doing so well in certain cancers that it's almost inevitable that the long-term effects are going to be de-escalated, and there be treatments evolving for conditions like peripheral neuropathy. So I see the future is bright.
I do too. Angel, you can see Dr. Shapiro and I doing doubles in pickleball down in Florida, right?
I'm probably going to be the water boy at that point.
Angel, Dr. Shapiro, I always bring my producer Angel in to see if he has any questions or if he feels we did a good job in providing this information to our constituents.
I think that what we've built up over these last modules since we started only put an icing on the cake, so to speak.
Yeah.
Having him on, having you tell me what we were getting ready to have on our show sheds light, and for me it's the culmination of everything.
Exactly.
So I thank you for just being a part of the show, and also being a part of his career too, because he was really interested in that article, and for that, as a viewer and as a producer, I say thank you.
Yep. And Dr. Shapiro, really from the community side, we are all grateful for you and folk like you who really have done all the heavy lifting and the innovation and the pioneer work. And again, I mean, thank you for joining us, of course, but thank you for your career. I want to take a quick minute and ask you if you have any questions of us.
I admire you. Let me give it back to you. I admire you because the community physician has to do it all. And I know one thing, and I know it well, but the community guys have to do it all and still be concerned with survivorship and still be concerned with all these issues. So I have great respect for the community guys like yourself, who, really are the salt of the earth, the really the front line of cancer care. And I thank you for your work in terms of building this podcast and initiating a survivor group. You were way ahead of your time, Tom, and I respect you for that.
Awesome. Well, just do me one favor. I need you to actually do me two favors. Keep feeding us the bullets on the front line because we need them. And number two, please promise to come back on the podcast.
My pleasure.
Awesome. CROC Nation, this ends the end of our Defining Survivorship module. Dr. Charles Shapiro, Professor of Medicine from Mount Sinai. Our gratitude shout outs, Angel Santana, Have Faith, Let It Begin, Rod Freeman, Small Biz Up, MichaelJohnBezea.com, and CharlotteLarson.net on the West Coast, who are our patrons. God bless you all. And as I end every podcast, I wish everyone, all of our survivors, all of our caregivers, a long, healthy, happy, and cancer-free life. Until next time.
Amen.
Hey, CROC Nation, if today's message inspired you, please subscribe, download, and share this episode with your friends or someone who you believe needs it. Visit us at crocvip.com to connect, learn, and join the fight. Let's spread hope, one story at a time. Until next time, remember, we are not just a podcast, we are a movement.